The committee will come to order. This is the Congressional Oversight Committee. We exist to secure two fundamental principles. First, Americans have a right to know that the money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty on the Oversight and Government Reform Committee is to protect these rights. Our solemn responsibility is to hold government accountable to the taxpayers because taxpayers have a right to know what they get from their government. We will work tirelessly in partnership with citizen watchdogs to deliver the facts to the American people and bring genuine reform to the federal bureaucracy. This is the mission of the Oversight and Government Reform Committee. At this time, I'd like to ask unanimous consent that the gentleman from Georgia, Mr. Kingston, and the gentleman from Georgia, Dr. Gingrey, be allowed to participate in today's hearing. Without objection, so ordered. I want to welcome you all here today for this very important field hearing on the status of the Affordable Care Act's implementation, known to many of us as ObamaCare. I want to thank our committee's chairman, Darrell Issa, who unfortunately could not be here with us today, for allowing the committee to hold this hearing. I also want to thank my good friend and colleague whose district we are in right now, Doug Collins, for being the driving force behind this hearing. Without his incredible leadership, we would not be here today. This hearing would not be happening. I'm grateful to him for that. We know about the sticker shock that so many Americans are facing today, those self-employed individuals and small business owners who have been getting their insurance on the individual market canceled and are experiencing a rude awakening when they find out because of the Obamacare mandates, their policies can no longer be continued. But the new Obamacare policy costs more and covers less of the many products that are so important to them. Many more individuals are learning that their doctor is not available to them through their new and, quote, better plan. The numbers don't lie. According to an Associated Press report earlier this month, 900,000 Californians, 130,000 Kentuckians, 140,000 Minnesotans, and nearly 400,000 Georgians have received cancellation notices. In just those 4 states, that's nearly 2 million Americans who have already been affected by Obamacare's unnecessary mandates. At this time, I'd like to ask unanimous consent to insert that AP article into the record. Seeing no objection, so ordered. According to a recent Heritage Foundation report, Obamacare is succeeding in at least one area. It is destroying individual market competition. There are currently 360 insurers in America that serve at least 1,000 individuals. 360 insurers that serve at least 1,000 individuals. Under Obamacare, that number will drop by 29% to only 254 insurers. In Georgia, there are currently 11 insurers in the individual marketplace, but under Obamacare, there will only be 5. That's a 55% decrease in insurance competition. North Carolina will go from 12 insurers to 2, an 83% drop. And in 2 states, New Hampshire and West Virginia, there will only be 1 individual market insurer left under Obamacare. I'd like to ask unanimous consent to enter that Heritage Foundation report into the record. Seeing no objection, so ordered. We know that choice and competition drive prices down and increase consumer service. By driving insurers out of the market, Obamacare is doomed to result in higher prices and in a lower quality of care. And that's before we even begin to experience the certain turmoil that will result from the implementation of the employer mandate next year, when large businesses will have to consider whether to increase their costs in order to provide health insurance to their employees or simply dump those folks onto the exchange. The lead editorial in today's Chicago Tribune, the president's home state, noted exactly that large employers have no incentive to continue their insurance plans, and all of the financial incentives are to dump their employees into the exchange. But our witnesses today have been experiencing the turmoil in the individual market, experiencing that difficult transition firsthand. They can tell us the real world implications of the law, and hopefully we can find ways of reforming health care that will control cost and will increase quality without creating these negative experiences for so many Americans. With that, I'd now like to recognize my colleague, Mr. Collins, for his opening statement.
Thank you, Congressman. Thank you, Mr. Chairman. I appreciate being here, and I appreciate looking out into this room here, welcoming those who, not only my colleagues that are here from different parts of the state of Georgia, but also my dear friend from North Carolina, Congressman Meadows, who we share a boundary together. But with Congressman Woodall and chairing this and being a part of this day, I appreciate it. And with Congressman Kingston and Gingrey providing a lot of experience, I think we're going to have that opportunity today to talk about some really very real issues that are affecting not only Northeast Georgia, but America as a whole. And I'm pleased to be here in Gainesville and Hall County for the first congressional hearing in a little over 10 years. It's been here, but it's good. I can think of no better place, in my humble opinion, to be here than to hear from the nation and to hear the good and hardworking folks on how our federal government can serve the people better. I'm pleased to be here, and as thankful as I am to Chairman Issa and the Oversight Committee staff for the opportunity to hold this hearing today. I wish it could be under different circumstances. It absolutely pains me to see firsthand the devastating impact that Obamacare is having on our nation, especially our rural communities. The issues my constituents have with Obamacare aren't just political. The concerns I continue hearing demonstrate a fundamental philosophical difference between the people of Northeast Georgia and the folks who support Obamacare. First, folks in Northeast Georgia and throughout rural America know what it is to live in community. They are generous people who come alongside those who are in need. Doctors and patients in rural America have traditionally been more free to come up with payment arrangements that work for them, so not everyone depends on health insurance. When a major medical expense comes up for someone who can't afford it, it's people who come together many times in these rural communities. A community knows itself far more than the Washington bureaucrats, and they have far greater interest in meeting the needs of their friends and neighbors than a government agency. The one-size-fits-all nature of Obamacare is an affront to those who know two communities are the same and not just a one-size approach. Northeast Georgians are also used to living within our means. Whether we're talking about a dream vacation or sending our child to college, we make financial plans to save enough money to pay for what we want. We're used to making sacrifices to meet our goals. That's why we can't understand a government that already has catastrophic debt passing a $2.6 trillion health care bill into law. Even if all that money was well spent, that's a lot of money to spend today to have our kids and grandkids pay for tomorrow. What rubs salt in the wound is the way that taxpayer money that's been poured into Washington bureaucrats and websites that don't work has literally been wasted. For a president who has talked so much about economic stimulus, I wonder if he's considered what our economy would look like today if he had taken a more realistic approach to health care reform, an approach that didn't create so much uncertainty and take so much out of Americans' wallets. But the biggest fundamental difference between the philosophy of folks in Northeast Georgia and the philosophy behind Obamacare can be summed up in two words: individual liberty. Around here, we believe, as the founders did, that the function of government should be limited to those that allow each American to pursue their own life, liberty, and happiness. Remember, the founders said that we're to have the pursuit of happiness. They did not say the guarantee of happiness, because we have to be a part of that process as well. It's fine for someone else's pursuit of happiness to look different from ours, but frankly, we get offended when someone imposes their version of American dream on us because each individual story and success is unique. We don't believe the federal government has the right to compel individuals and families to purchase a product or a service. Even if this administration had managed a flawless rollout of Obamacare, rural Americans would still have issues with this law, but implementation of this bill has been far from perfect. As I look at our panel of witnesses, one point is abundantly clear. Each of you are here because the President's promises have failed you in some way, or they failed someone you know. The barriers to accessible, quality health care in rural communities are great, but as a result of Obamacare, they are now devastating. In Georgia, 3 rural hospitals have shut down already this year, and some estimates indicate that 15 more may be closing their doors in the coming months. Many of you here today probably have growing concerns about Obamacare's impact on you. You may have questions like, will I still be able to go to my primary care provider? How far will I have to drive to get the medical services I need? Will I get to choose among several different providers or just one? Or maybe it's even more basic than that. Maybe you're just wondering if you have the ability to keep your job, or if your employer will lay you off because they frankly can't afford Obamacare. Last month, the New York Times reported on the lack of competition in many rural communities, resulting in higher premiums. The Times wrote, in rural Baker County, Georgia, where there is only one insurer, a 50-year-old shopping for a silver plan would pay at least $644.05 before federal subsidies. A 50-year-old in Atlanta, where there is 4 carriers, could pay $320 for a compatible plan. Despite the spin that the president and his people try to put on Obamacare, the facts speak for themselves. Families in rural communities will pay more for health care under Obamacare. Of the approximately 2,500 rural counties served by the federal exchanges, 58% have plans offered by only 1 or 2 providers. In fact, 530 counties are only served by 1 provider. Today, we're going to highlight what the title of this hearing suggests, the high cost and scarce choices facing rural Americans under Obamacare. But I also want to talk about solutions. I'd love to hear what our witnesses think Congress can do to promote affordable, accessible medical care in their communities. Once again, I'd like to thank Chairman Issa and his staff, all of our witnesses for being here. I look forward to a constructive conversation and hope we get some ideas about how to best move forward from here. And with that, I yield back.
Thank you, Mr. Collins. Now I'd like to recognize the gentleman from North Carolina, Mr. Meadows, for his opening statement.
Thank you, Mr. Chairman. And I want to open up by saying thank you to each one of you who showed up today to hear this hearing. I actually represent Western North Carolina, 17 counties from Lenoir, Hickory, all the way to Murphy, and we share a common border with Congressman Collins. Not only is he a good friend, but he is someone who really puts the care and concern for the people he represents first. I can tell you firsthand in talking with him on a weekly basis, there's not a week that goes by that he is not saying, well, how does this affect the people that I represent? And see, not only do you have a great representative, but I want to thank you because on a Monday before Thanksgiving, I know there are many other things that you could be doing, and yet you are here to express your concern about how this Affordable Care Act that is turning out not to be affordable is affecting you. And so I want to just say thank you for coming. I want to thank the witnesses for coming and being willing to share your testimony today. We look forward to hearing from you, hearing that expert testimony, and how we can indeed fix it and make sure that it doesn't affect the people in a more adverse way than it already has. Many of the facts and figures have been shared today. I can tell you over 473,000 people in North Carolina have lost their coverage. When it comes to being affordable, we're finding out that indeed it is not affordable. You know, even though there were promises made that we could somehow have some insurance policies were $2,500 less, I can give you example after example of people that are having to pay between $2,000 and $8,000 more a year to get the same health care coverage under this new law. That is troubling to me. I know it's troubling to most of my colleagues, in fact, all of my colleagues here on the dais. But I also want to say there are a number of other areas that we need to address. We had a hearing recently in Washington, D.C., where we talked about security and the fact that there has not been a comprehensive security test of this website that continues to malfunction. That is very troubling to me in a time and day and age of identity theft where we would put forth something that should have confidence where people could put in their information, and yet we have not done a comprehensive security test. In fact, in that testimony, they were saying that it may not be done for another 60 to 90 days. That is troubling. We had one expert testimony given that said that the best practice would be to take down the site until we can do that security testing. And the question before many of us today is why are we not doing that? We're continuing to rush on to try to meet a November 30th deadline for this website so that we can do that. And even with that, even if it does get up and running, we know that there are a number of other areas that have been promised that will not be addressed. I also want to just say that for rural communities, I represent 17 counties. Most of them are very rural. When it talks about health care and keeping your doctor, that is a critical component because, quite frankly, we don't have the choices that you might have in Atlanta, Georgia, or the choices that we might have in Washington, D.C. Because, as you know, healthcare providers, there's a long distance. We've got Dr. Reinhardt is going to be testifying today. I can tell you when we had our 2 children, we had to travel over an hour and 15 minutes for delivery for my son and daughter. It is not like you just go and check into the hospital right around the corner. It is different. So I just want to say thank you. We look forward to hearing the testimony, and I know the chairman will be addressing how many of you can provide your testimony for the record. And I just, again, thank the chairman, thank the committee staff. This is an unbelievable staff on oversight and government reform. They're diligent on not only on this issue, but a number of issues. And to have these hearings where we come out from Washington, D.C. takes a tremendous amount of work. So my thanks to the committee staff, to the folks here at Hall County for being so gracious and hospitable, and I yield back.
Thank the gentleman. I'd like to yield the gentleman from Georgia, Mr. Kingston, for his opening statement.
Mr. Chairman, thank you very much for letting me join you. And Mr. Collins, it's always great to be in your area, and thank you for letting me come. And same to you, Mr. Meadows and Dr. Gingrey. I'm proud to be on the dais with you. As you know, I chair the Appropriations Subcommittee of Health and Human Services, which does the financing for the Affordable Care Act, but also Medicaid and Medicare and Social Security and CMA and so many other the vital programs that so many Americans use. So we're very concerned about this from a price tag point of view. And I just wanted to touch base on a couple of quick things that I want to submit for the record. But one, in terms of the objective of Obamacare to reduce the cost of premiums, one need not go outside of his own household to hear stories. My daughter, who's a 30-year-old healthy young woman, had her premium go from $160 to $270 a month. And I talked to so many businesses who have experienced the same thing. Talked to a parking lot company in Atlanta, Georgia, 1,000 employees. They put 900 on a part-time basis. I talked to another business in Cobb County, Georgia, a business that was growing. They stopped at 42 employees because they knew once they got over 50, they would have a whole new set of rules and regulations under the Affordable Care Act. And so you just think about stopping the growth that you could be having. Talked to a hospital in South Georgia, and this is a real interesting story of unintended consequences. The hospital identified 65 people which are frequent visitors to the emergency room. 65 people who go basically to the emergency room on a regular basis for their health care needs. What this hospital is doing is actually taking out insurance policies on these 65 frequent visitors. And under Obamacare, they'll be able to pay the premium, subsidized for these people, and then be reimbursed for the cost of their medicine and actually come out ahead thousands of dollars by legally gaming the system. Got a letter from Leonard Blunt in Statesboro, Georgia, who is the president of Capstone Benefits. It's a company that deals with health care. He said that he had a high deductible plan in which he paid for just about everything until the deductible is met. His premium went from $8,020 a year to $14,608. But he wasn't complaining about the large premium increase. What he was complaining about is that his health care high deductible plan has been canceled and is not offered anymore. And the government sent him a letter saying, but do not worry, and this is the exact quote, be assured that your new plan meets the requirements of health care reform law and provides the major medical benefits and strong financial protection that you need. And he said, please, the government in Washington has no idea what I need. My wife is 58 years old. Why would she need prenatal care? And that was what his point was, is that I don't mind the premium increase as much as I'm outraged that the federal government is now dictating to me what my family in Statesboro, Georgia needs. I want to submit that for the record. And so, Mr. Chairman, there's so many cases of this. I will submit these. I have another one from Signature Aviation in Savannah where they said our health care premium went up, therefore writing a tenant saying we're just passing the cost on to you. And I'd like to submit that. But thank you for letting me be with you, and I look forward to the testimony.
Thank the gentleman. Without objection, those documents will be submitted into the record. Now I'd like to recognize the gentleman from Georgia, Dr. Gingrey.
Chairman Woodall, thank you very much for giving me the opportunity to be here in Hall County, Gainesville, and Northeast Georgia for this very important field hearing, and to join my colleagues, of course, Congressman Doug Collins of the 9th, and Congressman Kingston from the 1st, and Mark Meadows from North Carolina, a great member. I want to just kind of tell the group that's here, and it's a large group, obviously, that this is just exactly what we do in Washington. This is a hearing. If there are any C-SPAN junkies in the room, and I'm sure there are, and you watch these hearings sometimes late at night, this is exactly the way it is. You have the committee. The committee, of course, is usually the full committee, and then 4 or 5 witnesses. Sometimes you'll have more than one panel. In this case, we have one very important panel. And then the audience. Now, this audience this morning is just about as big as any audience that I've seen in my 11 years as a member of the House of Representatives. Oversight is one of the most important things we do. Congressman Kingston mentioned appropriations, of course, paying the bills, spending the money. But then once those things are committed to follow up and to have oversight. And Oversight and Government Reform is a separate committee, and it is the main committee. And I commend Doug Collins and Rob Woodall and Chairman Issa. But each committee in the House of Representatives actually has an oversight subcommittee. And we all do this. I sit on the Energy and Commerce Committee, and we have jurisdiction over all of Medicare Part B and C. We have jurisdiction over all of Medicaid and also Peach Care, the S-CHIP program. And we have an oversight subcommittee. I sit on both the health and the oversight subcommittees of that committee. So that's the reason why we're doing what we're doing here today. This is just like what would be doing in Washington, but this obviously is called a field hearing because we're in these districts and we want to know. We want the audience to be the people that are most affected by ObamaCare. And of course, the witnesses to be the experts on how it has affected them. So I just wanted to kind of lay that out there and tell you, and right from the very start, from my perspective, how I feel about it. The federal government would literally torch a village to kill a gnat. And that is their whole attitude toward things. What has happened to federalism, which this document talks about, and I'm sure all of you believe in, local control and the ability to maintain your own liberty and to buy your own health insurance in the sanctity of the doctor-patient relationship. Sure, the media and the Democrats and this administration high-fived each other March the 23rd, 2010, when this Obamacare became law, because they said, we've been wanting to do this for 100 years. Well, did you ever think of why maybe they've been wanting to do it for 100 years? Because people 100 years ago didn't want the government to take over health care in the days of Woodrow Wilson and Franklin D. Roosevelt and whoever was trying to push it on their side of the aisle. And today, even as we speak, 61% of the American people are totally opposed to this abomination. So I think from that little bit of preface, other than going off my prepared remarks, you get a general idea of where Congressman Gingrich feels about this law. And I definitely look forward and thank the witnesses for being here and look forward to their testimony. I've been hearing from my constituents for the past 7 weeks about these higher premiums like my colleagues are talking about. Their anxiety over finding coverage and even the law's impact on their ability to keep their doctor, to keep their hospital, and to keep their insurance. It's clear that this law was misrepresented from the start. It neither protects patients nor affordable, both to individuals and to the government. The president's law gives control of 1/6 of our economy to Washington bureaucrats, and it imposes a tax increase on middle-class Americans and small business owners, many of our witnesses. As the government becomes more involved in health care, doctors and patients become further removed from their own care decisions. Dr. Reinhardt will tell us about that. And this results in a more expensive and a more dysfunctional system. A constituent recently told me that the law has become a financial disaster for his family. The fact is, the president's words, if you already have insurance you like, you can keep it, period, seem to be directly refuted by the millions of cancellation notices already sent to Americans in the past few weeks. Many more cancellation notices than sign-ups, right? It does strike me that millions of individuals voted believing one thing, and now they find themselves without coverage, and they're now scrambling to find coverage in a marketplace that offers only more expensive plans with fewer options for care. My colleagues have commented in regard to someone 55 years old, let's say a single male. Does he really need maternity care? And it's just ridiculous what they're trying to do. We can solve this problem, and I'll conclude with this. A lot of times the media, the talking heads on the Sunday morning shows will say, well, those Republicans, they just don't have any plan. They want to repeal, but they don't. What are they going to do about the fact that health insurance in this country, even though health care is great and it allows the average man to live to age 78 and the average woman to live to age 80, that's far different than back in the 30s when we first did Social Security, in the 60s when we did Medicare. So we do have the greatest healthcare system in the world. We just need to address the issues that are making it too costly. And here is a bill. Here is a bill, a comprehensive bill called the American Health Care Reform Act. There's 7 bullet points on here, not 2,700 pages. I'm not going to take any more time to go over this, but of course we have a plan. Some of it involves health insurance reform, but of course we have a plan. But we never get the media attention. We never get the press. Let me tell you, that's why I say repeal or go home. I yield back, Mr. Chairman, and thank you so much for giving me the opportunity.
Thank you, Dr. Gingrey. It's now my great pleasure to welcome our first panel of witnesses. Beginning left to right, we have Mr. Raymer Sale. Mr. Sale is the founder and president of E2E Benefits Services and E2E Resources in Duluth, Georgia, which provide employee benefits and HR administration. Mr. Sale founded E2E Benefits and E2E Resources back in 1993, and over the past 20 years, he and his staff have provided services to literally thousands of small business employers and employees. He's the immediate past chairman of the Gwinnett Chamber of Commerce, which is one of the largest chamber organizations in the state with over 2,100 members, and is a member of the Gwinnett Chamber Executive Board. His business has twice been honored as a Pinnacle Small Business Award winner, which distinguishes E2E Resources as one of the top 25 small businesses in Gwinnett County. I'd also like to welcome this morning Dr. Jeff Reinhardt, who's an OBGYN right here in Gainesville and the president of the Longstreet Clinic, which is one of the largest multi-specialty practices in Northeast Georgia. With over 550 employees, including more than 150 physicians and mid-level health providers representing over 16 specialties, Dr. Reinhardt's leadership of the Longstreet Clinic gives him an invaluable window into how Obamacare is already affecting hospitals and private practices. To his right, we have Mr. Michael Boyette, who's a small business owner in Ellijay, Georgia. His family's automobile sales business and his own health insurance premiums have been negatively affected by Obamacare, and he is here to give us that firsthand story, both of his family and of his business here this morning. And finally, we have Mrs. Emma Collins from Ellijay, Georgia, who is self-employed. Because of a pre-existing condition, she was uninsured, but her condition was manageable and her monthly health bills were very low. Her family has experienced tremendous insurance premium increases thanks to Obamacare, and her family is currently trying to navigate the complicated Obamacare website system. I think there are many Americans who find themselves in that very same situation as Ms. Collins and her family, and we're so happy to have her here to tell that story today. As is a custom with the Oversight Committee, pursuant to committee rules, I would ask all witnesses to rise and allow us to administer the oath. Please raise your right hands. Do you solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? I do. Yes, sir. Let the record reflect that the witnesses have answered in the affirmative. Thank you. Please be seated. In order to allow time for discussion, I'd ask you all to please limit your opening testimony to 5 minutes. We have your written testimony, which will be submitted for the record. You have a timing light there on the table in front of you. Green means go, yellow means we're coming to the end, and red means we're there at the end. It's now my great pleasure to recognize Mr. Raymond Sales.
Thank you very much, Chairman Woodall and members of the committee. Thank you for inviting me to participate in this hearing today, and I appreciate your interest in the consumers who are living through the implementation of the Patient Protection and Affordable Care Act. This law is complex and does not protect everyone, nor is it affordable in many cases. Consumers are frustrated with the failure of healthcare.gov and the high cost of many new policies. We're being led to believe policies in effect prior to 2014 are inferior. Inferior to whose standards? Most of the policies in effect now were purchased to fit the specific needs of the consumer. We're also being told that cancellation notices are really renewal notices, and this is not true either. The insurance companies are canceling an existing policy. You cannot have that one anymore. If you do not select a new policy, your coverage will terminate. By the way, state law controls this, and we haven't seen the backlash yet that will come when consumers find out their doctors may not be in the network. Once we get through the individual market, the small and large group plans will be front and center. They will be faced with many of the same issues that are affecting the individual market. Many will see higher premiums requiring new plan designs. You cannot keep your coverage unless it is a grandfathered plan. And just for the record, the insurance industry has known since 2010 that most plans would lose their grandfather status. Of the roughly 100 employer clients we serve at E2E, approximately 4 have retained their grandfather status, and E2E is not one of those. The law is loaded with opportunities for small and large employers to face severe penalties for not complying with one portion of the law or another. This begins with the age 26 notice that employers were supposed to have distributed back in 2010 to the summary of benefits and coverage that must be distributed at renewal, when an employee is hired, upon a qualifying event, or when requested. Failure to comply with this requirement could result in a fine of $1,000, and that's just one requirement. Documentation is imperative because you'll have to prove compliance. As the law matures, this gets worse as the employer is required to make sure their plans comply with PPACA plan design, track the hours worked by the employees, report the hours to the government, manage hours worked to keep an employee at part-time status to control costs, track seasonal employees to be sure they're added to the plan once they pass a certain number of hours, pay higher costs due to new taxes added to the premium. This is going to increase premiums 3 to 4%. I got one client that pays $10,000 per month in taxes alone. Got about 235 employees covered. Proof to the IRS an affordable plan is offered to the employee if an employee buys coverage from the exchange. Either upgrade payroll systems or purchase systems that track many of these items mentioned above. All of this is expensive and is a distraction from the main function of the employer, that is to provide services or products and jobs. EDE has spent thousands of dollars on software upgrades, purchasing new software, and educational training, so we'll be able to advise our clients. And many employers do not understand this law and what it means to their business because they cannot absorb everything they will be required to do in order to comply. Currently, most of the EDE clients who qualified have been moved to December 1, 2013 renewals called early renewals. This action is designed to defer many of the effects of PPACA until 2014. This early renewal action protects plan design, avoids community rates, controls cost, and gives the government time to observe the effects of the employer and correct or repeal this law. This is confusing to the employee and disruptive to the employer. Finally, a great concern is the legal exposure as a result of this law. Never in my almost 40 years in the insurance industry have I been concerned with legal action. We're very detailed and effective in the guidance we offer. However, as stated in the opening paragraph, this law is complex. Employers hire and expect EDE to provide the guidance that will allow them to comply with the law, and it's ripe with opportunities for government penalties and fine. To complicate matters, once PPACA became law, the regulators made changes to the rules here, delayed a portion of the law there, requiring businesses and consumers to change directions and spend additional time and money to comply and adjust. Constant last-minute alterations to the rules and the refusal to make permanent modifications that will improve the product build uncertainty, which is counterproductive, not to mention the lack of respect for the individual or business community. Again, thank you for the opportunity to be here today, and I look forward to answering your questions.
Mr. Sale, thank you for taking time to be with us today. It's now my great privilege to recognize Dr. Reinhardt for his opening testimony.
Good morning, Mr. Chairman. Committee members, fellow witnesses, and attendees, thank you for the opportunity to come to you before you this morning to discuss the impact of the Patient Protection and Affordable Care Act. As stated, I am Jeff Reinhardt. I am a full-time practicing OBGYN and president of the Longstreet Clinic. I wear several hats as it relates to health care. I am a consumer, a provider, and an employer, and I was asked to speak today in my role as a physician and provider of care. It is not new news, as Dr. Gingrey mentioned, that healthcare in this country is in crisis, dating all the way back to 1926. Out of concern for the cost and utilization of care, Congress formed a committee on the cost of medical care. This committee was abolished in 1932 after their recommendations were felt to be too radical. This illustrates that cost, access, and quality of care and the government's role in these issues has been ongoing for some 90 years. According to data reported by the WHO, the cost of health care in the United States changed from about 13.5% of GDP during the 90s to almost 18% this year. Last month, AON Hewitt, a leader in employee insurance benefits, reported that the average health care premium per workers has seen increases ranging from 3.3 to 8.5% for each of the last 7 years, with an estimated increase of 6.7% for next year. Also, noting a trend that has seen the employees' share of total health care costs jump 150% since 2004. Clearly, increasing cost is a problem. Access to medical care is influenced by geographic location, a person's literacy and disabilities, and the ability to pay for services. From 2004 to 2008 in Georgia, there has been a reduction in the number of OBGYN providers from 13.5 to 10.9 per 100,000. This will lead directly to an increase in preterm birth. That's bad. This reduction in providers is due to the lack of an increase in Medicaid reimbursement since 2002, increased cost of compliance with government mandates, such as electronic health records, lack of meaningful protections against frivolous lawsuits, and increasing student loan debt. In general, the universal access for health care is the emergency room. It is providing the appropriate location of care for people that is our challenge. The nearly 50 million uninsured non-elderly Americans receive much of their health care in the ER, with about 25% of all ER visits being non-emergent. CMS estimates the cost of this to the taxpayer is about $176 billion per year. Additionally, about 55% of care provided in the ER is uncompensated, meaning no payment at all is received for services rendered either by hospital or doctor. Historically, this charity care has been paid for with cost shifting. However, with the stagnant or declining reimbursements, this is becoming increasingly difficult and in some cases impossible. The imperative about quality is a tough nut to crack. Doctors and other experts can't seem to agree on the definitions of quality, and our ability to gather clinical data is poor. Well, here's what I know. When I finished medical school, I thought an exchange was what I did the day after Christmas with the sweater that didn't fit. Right now, I am struggling to educate myself about private exchanges, Medicaid expansion, and donut holes. I know that many of the problems discussed here this morning preceded the Affordable Care Act, and the old system was broken. I know that when the coordinator called me to testify this morning, I was in one of my rural offices, and the patient I had just seen remarked at checkout about how happy she was that she didn't have a copay for her visit. I know that her copay will eventually be rolled into the premium for her insurance, and that ultimately she will pay for it. I know that one of my dear employees and friends has been stricken with metastatic pancreatic cancer, and that her treatments would have bankrupted her if not for the elimination of annual and lifetime insurance maximums. For her, thank God for the Affordable Care Act. I know that particularly the parts of the Affordable Care Act slated for implementation in 2014 will bring great change, with real people tragically affected and others receiving great benefit. I know that it is too premature to know the full impact of the Affordable Care Act. I know that change is hard. I know that there is a lot of work yet to be done. And I know that I appreciate the opportunity to be here today and to present to you my impressions and thoughts and views and to answer your questions.
Thank you, Dr. Reinhardt. It's now my privilege to recognize Mr. Boyette for his opening testimony.
Thank you, sir. I'm here today to explain how the Affordable Care Act has affected me and my family. My name is Mike Boyette, age 28. My wife is 30 and my daughter is 2 years old. We have been residents of Georgia for 10 years. My wife is employed by the state as an educator, and I'm a small business owner. We have had health insurance through the state health benefit plan for the past 6 years. Our monthly premium with our current carrier, United Healthcare, is $350 a month. Due to the new healthcare law, our new carrier, Blue Cross Blue Shield, has raised our premium to $540 a month. This results in an increase of $190 a month, a $2,280 increase for the year. You may have think we went with a more expensive plan or have gotten more coverage. In fact, we have not. We have less coverage before, a higher out-of-pocket expense, and a premium that has risen 65%. This is not affordable to me. I do not believe my government tell me I have to buy something, and on top of that, if I do not, I will be fined. I believe the American people have lied to and misled. I myself like the president's promises that we could keep our same health care and that we would actually be saving money. This was promised and believed by me and many other Americans. For the year 2013, we had 2 companies we could choose from, along with 4 options each company provided. When we went to sign up for our new 2014 healthcare plan, one company was available with 3 options. One company, 3 choices. That was it. I thought I was wrong, and it was not possible that I would pay more and have less coverage and fewer options. This was not what the president assured me and many other Americans. When you hear the leader of the free world tell you something, you would like to believe his words have truth, meaning, and honesty. I do not believe this to be the case. More money, less coverage. Obamacare seems to hurt the majority of Americans while only having a positive effect on a very small percentage. I don't understand why this administration wants so badly to have the Americans rely on their government for food, housing, and now health care. It concerns me to look into the future. Should the government run the automotive business next, telling us that if we don't buy their cars, we will be fined? When does this stop? Please fix the issues at hand. Do not create more problems. Do not lie about it for political advancements. And I believe we all have been lied to. If I lie to my customers and tell them something is not true, I wouldn't have any business. They're wondering where their customers are. Well, they have lied. Therefore, they do not have any business. It is time that we as Americans stand up for what is right. This is very cut and dry. This is an Obama tax, not Obamacare. I would like to thank our elected officials and other Americans who have stood up and fought for this from the very beginning. I urge them to keep fighting for us and hope that they know those fighting for the American people are appreciated. I also hope that one day justice and real freedom and choice will be back in our healthcare system. While the future of my healthcare seems uncertain and far from affordable, I hope those Americans who have been negatively affected, like myself, by Obamacare, can reverse the wrongs that have been done to the millions of us. Thank you.
Thank you, Mr. Boyette. It's now my privilege to recognize Mrs. Collins for her opening statement.
Thank you very much. And good morning. Thank you for inviting me. I'm happy to be here, and I'm honored to have been chosen to participate in this hearing on the Affordable Care Act, and hereafter referred to as the ACA. My husband and I are both self-employed, and as such, we do not have access to group health care insurance. He is a certified quality auditor and an independent contractor. I'm a licensed massage therapist and I have my own business. We had group insurance when I was employed by a local school system. However, when budget cuts caused my position to be eliminated, we lost that option. So we researched private companies and applied with several. I was rejected by all these companies because I have a pre-existing health condition. So then we applied for just my husband and our college-age daughter so they could at least have insurance. We found a policy from Humana for them at $265 a month. It was basically catastrophic coverage, but that was fine. It was affordable and it gave us financial protection in case of major medical issues. Early October this year, we got a letter from Humana. The policy was being changed. For them to have a plan that was compliant with the requirements of the ACA, our cost went from an affordable $265 a month to an outrageous $898 a month. That is a 240% increase. In addition to this much higher premium, the deductible on this exorbitantly priced plan is $6,000 for one person and $12,000 for both. So in the event of medical issues with them, this ACA-compliant plan exposes us to the risk of up to $2,000 per month. That is in no way, shape, or form acceptable or affordable. With the low premium plan that we had, we were willing to accept the risk of a high deductible, but it is just not feasible to combine a high premium with a high deductible. It's not like my husband and daughter are even at high risk for illness for the plan to be so expensive. They're both athletic, long-distance runners and are extremely healthy. So for their rates to increase at this ridiculous amount is just simply unreal. I still don't know what I'm going to do about health insurance for myself. I'm very concerned about how much it's going to cost. If it's anything like my husband and daughter's case, it will be anything but affordable. I haven't signed on to healthcare.gov yet to find out the true costs for me. I'm very concerned about the security of my data, the potential for hacking, and the potential misuse of private information entered into that database at this time. My husband, my daughter, and myself are not the only ones in our family negatively impacted by the new health care law. Our married college student son, his wife, and their 4-year-old daughter apparently make too little to qualify for a subsidy. However, they make too much to qualify for Medicaid. It makes no sense to set up a program where some of the very poorest financially among us are left out in the cold, while those who make only slightly more are given free, large S. While I was looking for information on the public pages of healthcare.gov, I noticed something curious. On all the pages I looked, the subsidies were promoted. It was implied that most people would qualify for a subsidy and that their premiums would probably be lower than the ones quoted on the estimation page. But even with the wide variety of financial situations in our family, no one qualifies. I think it's great to help those who are poor and desperately need help, but that is not what is happening. There is a great gap in the assistance to the poor through which our son and his family fall, and there is great inequality in how the subsidies are given to those with higher incomes. Why should Congress and staffers who are as well, or in most cases, financially better equipped than my family, receive subsidies when what we receive instead is outrageously priced health insurance or being required to pay a fine beginning next year at 1% of our income? The misleading advertising on healthcare.gov and unfair application of the subsidies all make this costly financial pill even more bitter to swallow. The ACA will also have a negative impact on our local economy. We currently employ people to clean our home, do yard work, and odd jobs around the house. That will have to stop because of the necessary tightening of our budget. This will reduce their income, thus reducing what they are able to add to the economy. We may not make such a dramatic impact just by ourselves, but we are not alone. Imagine this combined with all those others like my family and myself. Once happily contributing to multiple levels of the economy, now required to funnel most of that financial stream into the behemoth that is the ACA. So because of the ACA, our family will go from having some health care coverage we can afford to no health care coverage and a fine beginning next year at 1% of our income. Please repeal the ACA in its entirety. There has to be a better way that would not cripple families like us financially, yet would still help those who simply cannot help themselves. Thank you again for your time and consideration of this extremely important matter. May God bless you with wisdom.
Thank you, Ms. Collins. Thank you all. I'll begin the first round of questions. And Ms. Collins, I think you hit it on the head with your ask for a blessing of wisdom. I was with a member of Congress a week and a half ago, and he He noted how many state legislators had been elected to the Congress, and he wondered if a wand of wisdom was suddenly passed over you when you went to Washington, D.C., that you believed that Washington had all the answers that you couldn't find while you were a state legislator. Mr. Sale mentioned that this is a marketplace that our state legislatures and regulators have been working in for a long, long time. In fact, I saw Senator Renee Unterman with us this morning. I really do believe that the level of conversation has increased dramatically. The focus. I remember back in 1996 when the feds had eliminated pre-existing condition for federally regulated plans, but they didn't try to interfere in state regulated plans. But as Dr. Reinhardt pointed out, lifetime caps, the elimination of those lifetime caps has been something that both consumers and the industry itself has come together to say, you know, this is something that we could do. I sincerely believe if we had voted on the Affordable Care Act 6 pages at the time instead of 2,400 pages at the time, there would have been some benefits in there for some folks. But we would have rejected so many of these things that we continue to talk about rejecting today. It is you and your family, Ms. Collins, that were the poster child of why we need the Affordable Care Act. And here you are, the very family that we intended to help, saying we have not done so at all. At the same time, Mr. Boyette believed those promises and is finding them unfulfilled. You talk about subsidies on the web page. When I heard that every family's policy was going to be $2,500 cheaper under the Affordable Care Act, I thought it actually meant that premiums were going to go from a level that we all thought insurance costs were too high, and insurance costs were going to come down. But it sounds like from your reading of the webpage, what it means is premiums are just going to go up even higher, but we're going to create enough of a federal subsidy to try to bring those down below what we were paying before. Is that an accurate reflection?
That's how I perceived it. It was that basically they'll take from those that make too much to get the subsidy to give to those who will receive a subsidy. But even at 75%, if it covers 75% of these plans, I've been at incomes of those people that have the eligibility to receive the subsidy. It's still going to be a very painful financial burden, even paying that 25%.
Well, Dr. Reinhardt, you talked about the folks who are receiving non-emergency room care and the literally hundreds of billions of dollars that go out the door in that way. I don't believe there's a man or a woman in this room that does not believe that folks who have no health care choices in their life deserve and require access to health care. That seems like a solution, a problem that we could come together on a solution for. We don't want those folks in the emergency room. Is it your expectation that what we're seeing under the Affordable Care Act is going to eliminate that emergency room traffic?
I think the degree to which it will reduce that is going to be measurable. The degree to which that gets changed is going to be unclear, because part of what we will do in this process of trying to provide a more appropriate location for access is we will have to retrain people. So historic patterns of seeking care, habits, if you will, are hard to break. And so those individuals that will get coverage or be provided coverage through federally qualified care centers, subsidized care centers, if you will. I think retraining them that is where they go for their care, I think that's going to be a great challenge for us. So the degree that which you will reduce that 25% of non-emergent visits to the ER, I think that's going to take time to be able to calculate.
Well, I do think there's a common commitment to improving access. My uncle's a primary care doc down in South Georgia. He said, Rob, you can hand out all the new Medicaid cards you want to, but I'm the only doc in 5 counties who'll see Medicaid patients, and I can't fit anybody else in my waiting room. So that handing out cards doesn't improve access. You talk about the number of OBGYNs per 1,000 Georgians going down. I cannot imagine when we're creating an incentive for doctors not to get in the business, or even worse, for docs with experience and talent to leave the business. If we continue to see the ratio of docs to patients declining, we're going to end up with access issues. There's just no way around it. And Mr. Sale, what I understood you to say was that of 100 clients that you looked at whose plans were supposed to be grandfathered under the, if you like your health care, you can keep it, something that was designed to mitigate problems that folks knew would occur, that only 4 of those companies still maintain their grandfathered status today?
That is correct. Most of the plans were lost their grandfather status because the insurance carriers made a dramatic change in the benefit structure. Early on, when the law was passed, they said if you even change carriers, you lose your grandfather status. And one of my larger accounts lost grandfather status by June of 2000, I believe it's 2010. So most everyone is gone, and the ones that we've found that still have it were caught in the early renewal changes, just moving their renewal dates to December, and we found 4 of them that actually still had grandfather status. That we had done all the rules, we'd done all the compliance that the employer needed, but we just didn't keep up with them until we came to this renewal status.
And finally, thinking about Ms. Collins' request to repeal and start over from scratch, that's the same request the Chicago Tribune is making. But all the turmoil that we're seeing that is creating that desire to repeal and start over again, did I understand you to say that what we're seeing is just the tip of the iceberg, that folks are going through a process called early renewal to try to mitigate the damage that is happening, and when those early renewals are expire, there's going to be a whole nother round of insurance complications?
No, this is true. What we have done in our practice, and what many agents have done at the encouragement of the insurance companies, is to change the renewal date from whenever it was going to occur in 2014 to 2013, because they avoid the plan designs that are going to be required, the metal plan designs, if you will. They avoid the community ratings, which are going to be they're going to be a big eye opener when they hit the board too. The problem we have here is it's going to be real difficult for me to renew another group of 100 employees, 100 employer clients in December of next year. So there are going to have to be some changes. But the foundation behind this is to give, just like when the healthcare.gov hit the streets, and all the politicians, or not all of them, but the administration, better word, was touting, it's going to work, it'll work, don't worry about it, everything's protected, it's going to be flip the switch on October the 1st and your life is going to be a new life. Well, that's going to happen again whenever all these other renewals start in 2014. People have to actually live it until so they can believe it. I can tell you all day long your premium's going up 20%, and you're going to say, okay, well, you may be biased, you're an insurance agent, I understand, but is that really true? And then somebody else is out there saying, those things really aren't true, they're just pulling your leg. It's true, and I can assure you come 2014, it's going to be another firestorm out there.
Well, there are a lot of folks this holiday week who are thankful that they have not yet been adversely affected by the Affordable Care Act, but it sounds like this is just the beginning, and there is more, sadly, pain and frustration for American families to come. With that, I'd like to recognize the gentleman, Mr. Collins.
Thank you, Mr. Chairman. I appreciate it. What is interesting to me is you talk about this, we look at it from a different perspective, is a fundamental difference. I spoke about that a little bit in my opening statement. A fundamental difference in government's role, and also a fundamental difference in what's actually happening in healthcare and what should be happening in healthcare. This concerns me, and it came out in Dr. Reinhardt's testimony. Michelle, you just brought it out just a moment ago. I heard a quote early on after they started getting their renewals and started looking at. I heard this quote, and it was from, I believe it was California, I'm not exactly sure, but the quote was, I liked this Affordable Care Act, but I didn't realize I was going to have to pay for it. And I think that's a fundamental problem when you look at this. And really what it is, and Dr. Reinhardt, I'm going to get my first question into you here. You've brought up something, it goes back to an old literature, it's the tale of two worlds, or a tale of two cities, however you want to put it. You've got those that are benefiting, and I'm not going to deny in this room that there are some who see a lower premium, their coverage. There is some benefits which could have been addressed without changing the way we deliver health care in this system and without a government basically takeover. But at the same point, you're also having people lose their health care. You're also, in the way that as Mr. Boyette described, you're changing. Are you seeing this in rural health care maybe exasperating this problem, that some might actually get a little help, but in actuality we're taking on the rural health care problem and making it a lot worse?
Well, I think none of this happens in a vacuum. So a lot of the statistics I mentioned this morning were data that was collected before 2010. So it's pre-Affordable Care Act. These issues have been going on for a long time. That reduction in workforce of OBGYNs was between 2004 and 2008, pre-Affordable Care Act. So these are issues that I think we have to address. You know, if you think about it from the perspective of, let's look at it from my perspective as a physician who finishes his residency and comes out here into the outside world. And let's say I had finished in 2009 and I came out here and I'm slapped in the face with a 906-page Affordable Care Act. And I'm in a partnership with 4 other doctors. What do? Do we each take 150 pages and go home and read it overnight and come back together the following morning and say, okay, this is how we're going to implement this? Heck no, we're confused. We need advice. We need help. And so we have to, through the economies of scale, you know, hire somebody or merge with another organization who has the faculties to help me as a provider adhere to laws. The HIPAA law, you know, EMTALA, these are laws that preceded the Affordable Care Act. This is not a new problem created by this. And so what's happened is you have had a lot of consolidation of providers, a lot. You have small practices that can no longer function in that capacity. Many of these people are seeking job security, just like you and I, just like the members of this panel. Job security seems to be with the people with the deepest pockets, and that's our hospital systems. So you're seeing physicians begin, well, it's a decade-old trend, but they are being hired by larger medical groups like myself or by hospital systems. Well, law in this country allows hospital systems to charge more for the care that they provide, a significant amount. So if you have providers in rural areas, okay, that are now employees of hospitals, you've reduced the number of providers. In many cases, you probably reduced the insurance companies that are participating with those providers. And you have elevated the cost of care because now you're paying more for the very same thing you got last year at the very same place. Yeah. That wasn't the fault of the Affordable Care Act, but the Affordable Care Act is another one of those 900-page laws that is just putting another stone in our pocket of burden. This consolidation has forced a lot of scrutiny around where I go as a provider to provide care. And this is the answer to your question. Many of these providers are beginning to be consolidated into more urban areas. So care that we may have been providing in more rural areas, it's no longer there because your doctors and your providers are being consolidated into more urban areas. The full extent of that, I think it's too early to know. We had 3 hospital closings this year, but if you look at MedPAC data, they will tell you that there's plenty of hospital beds available in this country. The Affordable Care Act was meant to provide care in the proper place, and for many of these hospitalized patients, the proper place is not in the hospital, so it actually motivates care out of the hospital. So that has freed up some hospital beds. So is it because the Affordable Care Act is working and it's forcing people into a more appropriate location of care, which is out of the hospital, or do we have a stable number of hospital beds? I don't know the answer to that question.
Well, one of the things that you hit on, and then just in the roundabout of the question is, I think what we have here is a healthcare setup that had an ideological bent. This is what we want to do without the look at the cost. And also, I believe it was set up by folks who signed, basically have not owned businesses, have not run businesses. They basically signed the backs of checks instead of fronts of checks, as I've said before. And I think when you look at that, that's a whole different process. Real quick, then I know my time is out, but I do want to ask Mr. Boyer, you've made an interesting comment that I think Ms. Collins sort of jumped on as well. It's the issue that's not talked about. We talk about the shifting cost of exchange costs. We talk about the, how much it's going to be and who lost, who didn't. But what you brought up was an interesting process, and those of the vast majority of people, remember, most people had health care before this. This was not an issue that we're grouping a group. But what you said is really interesting, and I think it's going to be really interesting here in the state of Georgia for all state employees, is this issue of now you went to one provider with 3 choices. Absolutely. And I think and that affects you. How does that affect, what I want you to elaborate more, because you touched on it briefly in your testimony. Did you find that shocking? Like, frankly, I have that kind of issue in my own household, so.
Well, absolutely. I mean, that's, variety is the spice of life. We like to pick and choose what, and when you go from 8 options to 4 options, and the whole time believing that it's going to get better, our healthcare system's going to improve, And when you see it firsthand, it's not. It's it's very disappointing.
Well, I think that's something for everyone to understand here is that the Affordable Care, the insurance industry, just like every other industry, is going to find ways to adapt to what they have to do. And if they have to give a cheaper premium over here, they're going to find other ways to cut their costs and make premiums go up on the other side. And I think you brought something that's often missed in this process.
That's where it hurts the most. It hurts the most when it hits your pocket. I mean, just like Ms. Collins here and myself and many other Americans, it hurts the most when it hits your pockets.
Your comment right there, hurts the most when you hit your pockets, is sort of why we're sitting here today, and something that was promised as a.
Oh, I watched the YouTube clips the other day. It's heartbreaking.
It is. It's promised as a cotton candy world, and the reality is cotton candy goes away, life comes on, and you get a premium, and you get a process. It's not just right now, but it's going to fail in the future. And with that, my time is out. Mr. Chairman, I yield back.
Thank you, Mr. Collins. I'd like to yield now to Mr. Meadows, North Carolina.
Thank you, Mr. Chairman, and thank each of you for your testimony. And I know, Mr. Chairman, this is not a town hall, but in going around, there were a few individuals that I know had some testimony and so forth. One particular gentleman had talked about how he had lost his coverage as part of a pension plan. And so I would ask unanimous consent for anybody who has written testimony that they have 7 legislative days to be able to submit that testimony as part of this hearing.
Without objection, if anyone has testimony, they can submit it to the Oversight Committee within the next 7 days, and we'll make that part of the official record.
And if the gentleman, Joe,
Sure.
And for those, and especially being here, you can call my office and we'll facilitate getting your stories in. You just contact us. So many of you here, my office, you just get that in and we'll present. I appreciate the Chairman.
I thank the chairman. Dr. Reinhardt, let me follow up a little bit with you, and then I'm going to come to you, Mr. Sale, with some questions. You identified some issues. Is there anything in the Affordable Care Act that you believe will help that trend of doctor shortages, where you were talking about that was a trend, I think, that was happening up until 2008 and continues on now. Is there anything in there that you believe that will allow us to have greater physician accessibility in rural areas?
You asked 2 questions there. You may not realize it, but you asked about the doctor shortage. I've been asked this question before by my state legislators about whether or not there's anything in there that'll stimulate more physicians to go and get trained. And the answer to that question is, if there is, I haven't seen it, heard it, or read about it. The second question, though, that you really kind of asked in there as well was access. Like, are we going to be able to deliver providers into areas where it is underserved? And there is some money in the Affordable Care Act that is supposed to go to provision of community health. I have looked at data from 2007, 10, 11, 12 at number of providers in those facilities. Again, these are the federally qualified health centers. I have looked at the numbers in terms of the number of patient visits, and it is all going up. Again, I think it's hard to know whether or not this is an increase in the number of providers to these areas. There are some inducements about paybacks for student loans in there. So if I was toting around $200,000 of student loan, which is roughly the average nowadays, which is a house and a half for a lot of Americans, I might be induced to go into a rural area and work in one of these centers. So there is some language in there and some mechanisms in there to begin to bring care providers into some of these underserved areas.
All right, let me go on, because maybe it's just in western rural North Carolina that we have this issue, but in rural areas, high-speed internet is not always available, and in fact, a number of my counties, it's very difficult. Access to healthcare.gov or even computers to get on because of the low income level. Are you finding the same thing in Georgia here?
I think there's no question that the access, there is some presumption in this process that access to the computer is available to everybody. And, I don't think that's, I've developed Tourette's syndrome personally since where I curse a lot, since implementation of our electronic health record about 10 years ago. So
That'll be quoted on the news, I can tell you.
You just made that one.
sometimes the truth is funnier than fiction. But I think that and we have good access. So in more rural areas where your access is less continuous and less certain, I think we've got to come up with more creative ways to provide registration for these individuals in these areas that either don't have computers or where that access is intermittent.
All right. Thank you, Dr. Reinhardt. Mr. Sale, you, in your opening testimony, you mentioned something that was very concerning to me because Mr. Boyette was saying that if you could keep your health care plan, if you liked it, you could keep it, and that he banked on that. And yet you said, and correct me if I'm wrong, in 2010, insurance companies knew that there would be a number of cancellations. Did I hear you wrong, or is that correct?
No, you heard me correct. What happened and the way the grandfather law was designed, if you made certain changes to your plan, you would lose the status. At the beginning, if you changed carriers, you would lose the status. And employers were faced with 20 and 25% rate increases if they'd had an unhealthy year. And if they went to another carrier, they may get a 10% decrease in their rates. And so it was smart to change carriers to do that. And so you would lose grandfather status, and then you had to publish that your plan met your plan. You had to publish to the employees that you thought your plan was a grandfathered plan based on what you knew about it, and that letter had to go out to the employees telling them that their plan didn't contain or wouldn't contain some of the benefits that a non-grandfathered plan would contain. And so early on, we began to see this happening. I guess we were at an insurance company meeting when it was discussed that people would lose their grandfather status. I didn't really believe it because I thought that these plan designs would be sufficient to retain it. But in reality, it is true. And most all of ours have lost it. Now, one of the carriers that we use went through their portfolio and changed everything that they could, and that alone killed the grandfather status. There was no way you were going to keep it, and it just happened to be the largest block of business that I had was with this carrier.
All right. So what you're saying is that the 400,000 Georgia residents that the chairman talked about in his opening statement that has lost coverage here in Georgia, that is not a surprise to you based on what you knew in 2010?
No, sir.
Okay. Mr. Boyette, I'm going to finish with this because I'm running out of time, and Ms. Collins, I'll follow up with you with a few questions if we have a second round. But Mr. Boyette, much of what's been talked about out there with the Affordable Care Act is saying that the type of policy that you had before was really substandard. It was, they were just preying on your stupidity. They were just trying to, you didn't really know what you had. And what you're going to get with these new 3 options, 1 carrier option is really better, and that you really don't know the facts. How would you respond to that?
You don't know my policy.
Has anybody, let me ask you, has anybody from the federal government called you to ask you about your health care, or even do they know what your children's names are?
No, sir.
So they probably don't know your individual needs as well as you do.
No, not at all.
All right. I yield back, Mr. Chairman.
I thank the gentleman. I'd like to recognize gentleman, Dr. Gingrey.
Mr. Chairman, thank you. Mr. Boyette, the government probably does know the names of your children. That's part of the problem here. I'm so glad that the gentleman from North Carolina, Representative Meadows, mentioned about, this is not a town hall meeting, but to give everybody here, and it's such a crowd, and I sure hope everybody in the back can hear, because our hearing rooms in Washington are not this deep, and as I previously said, not always this well attended, but we definitely want to hear from you, and maybe we can even stay around just a while afterwards and take some individual questions, because I know In Washington, the situation is the same, the format is the same, the dialogue is between the members and the witnesses, and the questions are between the members and the witnesses, and not those in attendance, not the audience. But let me tell you, in Washington, the audience, for the most part, is a bunch of lobbyists, a bunch of special interest people who are on one side or the other of an issue. The audience today is we the people. We the people, who are, every one of you, being adversely affected by this. And my heart goes out to you. I wish we could have an opportunity to hear from all of you. The witnesses have all given great testimony, and I thank all of you, Mr. Sale, Ms. Collins. I can relate, I guess, more directly to Dr. Reinhardt, as we're both OBGYNs, he currently and me previously. And Mr. Boyette, this may surprise you, but my dad and his two brothers were in the automobile business, just as you are. And it was called Gingrey Motors in Aiken, South Carolina. And you're Owltown Auto in Ellijay, Georgia. Now, I'm sure you sell pre-owned vehicles. They sold used cars. But times do change. And honestly, I bet my dad, they made $50 to $75 a car at best. And in those days, there was no Medicare, there was no Medicaid, there was no Peach Care, there was hardly any welfare. But Mom and Dad kept shoes on us, and we went to good public schools, and we were clothed and fed, and did all right. We did all right. So that's what we need in a way to get back to that self-responsibility of pulling yourselves up by your bootstraps, and the federal government being there to help those who, through no fault of their own, absolutely can't help themselves. And of course I'm for that. But we've gotten to the point where, as I say, federalism is all the federal government, and it should be mostly the states and we the people, if you believe, as I do, this sacred document. So I will direct my first question then, Mr. Boyette, to you, and just real simple. Would you also like to comment on how this law will affect your family's financial decisions as you go forward? I know you have a young daughter, and I know you and your wife are expecting a new baby soon. Just what's it going to do to you in being able to provide food, clothing, and shelter for your family?
Well, as I said earlier, it's $200 a month more, my premium, what I'm going to have to pay out of pocket. It's a lot of diapers. All our expenses have gone up, and, anybody, will tell you that going to the grocery store, and this is just one more expense me, as an American person, I don't need. Just plain and simple.
Ms. Collins, you had mentioned in your testimony, and I wanted to just touch on this. I think you mentioned that it didn't seem right to you that members of Congress and certain staff of members of Congress were in Obamacare, had to sign up through the Washington, D.C., it's called the Health Link Exchange, but it's one of these federal exchanges that doesn't work. But that members of Congress had to sign up. And of course, the law says if your income is between 100% and 400% of the federal poverty level, I think 400% for a family of four is about $88,000 a year, that you were eligible for a subsidy. Obviously, at that higher level, less subsidy than if you made 100% of the federal poverty level, where your subsidy may be 75% of the premium. But President Obama, by executive fiat, or whatever you want to call it, said that members of Congress and their staff would still get this 70% supplement. You mentioned that in your testimony. I would like to ask you how you feel. I would like to know how the members of the audience, if they had a chance to ask a question or throw things, how they feel about a situation like that, in the lack of fairness of that.
Well, it disturbs me greatly. It's very frustrating. We're not rich by any means. We don't qualify for a subsidy, and that's okay. But I don't understand why people, for no virtue of their own other than their employment, get a subsidy to cover virtually all their insurance costs when my family's going to be financially devastated by this if we follow through. On the other hand, we also have our son and his wife and their daughter who do not make enough to qualify for a subsidy. They're not even up to poverty level. He's a full-time college student. She works part-time. They share in care of their daughter. They don't qualify for a subsidy, yet they make too much for Medicaid. So what's happening to them is they simply have no insurance. Now, I understand they will have a form they can sign so they don't even have to pay a fine, but that's ridiculous. They looked at insurance yesterday on healthcare.gov. I had looked at it before for them on the estimators. And on the cost estimator for their insurance, it was going to be at the cheapest level plan, almost 40% of their total income before taxes. They're going uninsured while members of Congress and staffers are getting 75% of their pay. There's something wrong there.
Amen. Well, I see my time has expired as well. Mr. Chairman, I wanted to ask Dr. Reinhardt a question, but I'll yield back and maybe there'd be a second round, or
We'll begin a second round right now, and I'll start that. I'll start that out because, Ms. Collins and Mr. Boyette are both on the receiving end of this. The folks to whom the promises were made, the folks that genuinely, I think there's a national commitment to making sure that folks have access to care. We have Mr. Sale and Dr. Reinhardt on the trying to make good on those promises end of things, which is a little harder. Dr. Reinhardt, you mentioned federally qualified health centers. I don't know if everybody knows what a community health center is. We've been funding those in this country for decades, and it's a community-based clinic where folks can show up for absolutely any need that they have, and based on their income, they'll be charged on a sliding fee scale to try to make those services that they require affordable. That sounds strangely familiar to me. Let's find folks who need access to care. Let's take a look at their income, and let's make sure they have appropriately priced care. I think about the hundreds of billions of dollars that have gone into compliance on this issue. I think about the $1 trillion, not figuratively a trillion, but actually a trillion. A million millions. They tell me if you started a small business on the day Jesus Christ was born and you lost $1 million a day, 7 days a week, every day from the day Jesus was born until today, you'd have to lose $1 million a day, 7 days a week for another 732 years to lose your first $1 trillion. We're spending that on the president's commitment to getting access. What would that mean to rural areas if we'd committed to spend $1 trillion on expanding those community health centers that you talk about? Because Mr. Boyette has said as plainly as anyone I have ever heard that he does not want the help that folks are trying to give him, that he was happier before. That strangely, he knows more about what he needs than we do. We have Ms. Collins, who is exactly who this bill was intended to help. She says it's making things worse, not a little worse, not one order of magnitude worse, but did you say 240% worse for your premiums?
Yes, sir. And that's just for my husband and my daughter. That doesn't even include the required coverage for me that I have no idea how much it's going to be.
And I ask you, Dr. Reinhardt, because you're in the caretaking business. You took an oath here this morning, but you took another oath a long time ago to care for people and their health care needs. Let's get past whether or not we care about each other. Mr. Collins, in his opening statement, talked about what it means to be in community with one another, what it means to care about one another. These dollars are going out the door. They're coming out of everybody's pocket in this room. I understand the president is heavily invested in this. The bill has his name on it. Could we have done any better? Could we have done any better? And do you believe your patients would be better served if we strip this language out and start over again from scratch? to identify exactly those concerns that you have on your mind?
There's got to be more than one way to skin a cat. Mr. Collins, I wrote down one thing, and it was what you said, and it is that it's people who come together. And whether or not we have the system we had in the 90s, 2000s, or today, as we morph from kind of the old way of doing things into this new way of doing things, there are going to be people who receive great benefit and people who are left in a difficult situation.
Well, help me understand that, because I trust you on that. Again, I trust my doctor. I get to choose my doctor. I hope I still get to choose my doctor in years to come. But I trust you. So when Mr. Boyette says he didn't have any complaints to begin with, he liked what he had to begin with, his family was well served to begin with, but here in this legislative process, he's been stripped of what he liked. Now he has something that he doesn't like. I don't understand why we had to hurt him to help the folks that you're talking about. I want to help those folks. I just don't want to hurt the Boyette family in the process.
I think the notion that one size fits all is doesn't work in most things in life, and it doesn't work here.
Mr. Sale mentioned that in his opening statement. He said the policies that were being outlawed were inferior policies. That's disappointing to Mr. Boyette and his family that he had something inferior. How does it feel to be superior now, Mr. Boyette? Have you?
I don't feel any more.
It is amazing to me, those things in life that I have done and done poorly, the failures that I have had in life, the ones that I caused and brought on myself, I feel a little better about. Those failures in life that someone else forced upon me, I'm still a little bitter about. And I see folks who are willing to take responsibility for the decisions that they make, and all they ask for is the freedom to make those decisions. I'll close with you, Mr. Sale. Following up on Mr. Meadows' question, you said there was discussion in the insurance community as soon as this law was passed. Arguably before the law was passed, as the language was being vetted and passed around the country, that the grandfathering language, the language that was supposed to be the if you like your insurance, you can keep it language, that folks knew from day one that had no possibility, that language had no possibility of making good on that promise. As an administrator to small businesses in a little old state like Georgia, you looked at that language in 2010. Was it obvious to you on day one that if you like your insurance, you can keep it? If you like your doctor, you can keep them, period? Was it obvious to you on day one that was a promise that could never be fulfilled?
Well, maybe not exactly on day one, but shortly thereafter, because the National Association of Health Underwriters either forwarded a document or produced a document that they felt that 80% of the plans would lose their grandfather status within the first couple of years. And I may not be exactly where it's 1 year or 2 year, which one it was. But as this law began to unfold, it became very clear. Now, just this 27 or 2,400 pages, whichever it happens to be, of document has been being gone through forever, trying to look under every bit of information we could figure. So it may not have happened on day one, but the law was passed on signed on March 23rd, implemented on September of 2010, and it was very close after that we began to get the rumblings that, yeah, because once the Congress passed it, then people began to delve into it. So yeah, it was pretty close up front, because even on the individual plans, you got 4 plans to choose from. The metal plans, the bronze, silver, gold, and platinum. But nobody's plan out there was gold, silver, bronze. They were all something other than that. And of course, then these new plans have so many more added benefits that are going to make life a lot easier for you. That includes free doctor visits for wellness and birth control pills and all of that sort of stuff that just inflate the cost of the plan and take the design basically away.
So, I believe that if you like your doctor, you should be able to keep your doctor. I believe if you like your plan, you should be able to keep your plan. I believe we should be able to take steps that reduce the cost of insurance in this country, and I believe we should take steps to take care of families that are dealing with lifetime caps and are dealing with pre-existing conditions. But I also believe that at the end of the day, the patients in the Boyette family should be able to decide for the Boyette family what policy is best for them, and the members of the Collins family should be able to describe what is best for them. I cannot believe that any proposal that comes out of Washington, D.C., that tells you that you don't know best for you can ever be the right plan for America. And with that, I'd like to recognize Mr. Collins.
Thank you, Chair. I think going back to this, and Ms. O, you made an interesting comment, and it's something for all of us here to realize. You could read, and I could hand it out today, lock the door, and say, okay, everybody read 2,700 pages of the Affordable Care Act. And I would ask you then, at the end of the thing, we'd have a test, I'd hand it out, and I'd say, okay, here's questions about this bill. And the problem is you would not be able to answer what the bill actually does, because the 2,700 pages basically stated at the end of every paragraph, to be determined by, to be determined by, to be determined by. And if we want to take that in perspective, we have an 8-foot high, literally, stack of documents that are the regulations that are being proposed on the 2,700. So in other words, yeah, the 2,700 is the inside of the trunk of the tree, and then you have 8 foot at this point, and still growing, regulations that are in effect. There's no way that you can honestly understand this. I think this is the part that has become the problem. From the state perspective, from the local perspective, from the national perspective, this is the issue that we've got to come to grips with. The state of Georgia chose not to expand Medicaid. I applaud them for that. I sat on the Appropriations Committee in Georgia. You couldn't afford it. We've got to get back to some basic common sense on this issue. And part of the problem we've got here is that Congress has passed bills, such as the Affordable Care Act, that had 2,700 pages, but also said, by the way, we're going to let you figure out how to deal with it. So I've got a flip question here. One, we're going to start with compliance costs, but then Ms. Collins, Ms. Boyette, I want to give you an opportunity. If that's sort of the professional, the doctor caring side, I'm going to prepare you now so you can just think about it. What could we do better? Given your circumstances, what could help you? And that's it. So I just want you to think about that. But I want to come back over here for just a second. Compliance costs from myself and also from the Longstreet perspective as well. We sort of danced around it. Give me sort of an idea of how much compliance costs are affecting businesses and doctors' practices and others that you're seeing right now.
I can't give you a dollar figure because I don't have one, but I can assure you that the employers are very serious on trying to comply, and they are having staff do things that we recommend. And what we're doing is we're sending out bulletins to our clients to say you need to be prepared to do this and you need to be prepared to do that. And then when we get specific issues, then we involve the attorneys at $300 and $400 an hour to get specific. I can't tell you the dollar value. Dr. Reinhardt may be able to tell you exactly what's going on in his compliance, but we have in my office, I know we spent almost $800 on one piece of software that would allow the employer to see if their plan qualified under the pay rules. We have spent about the programmers right now in the middle of about a $2,500 modification to our HR software that will allow the employer to track hours worked each week inside a calendar month so that they can determine what where the employees are full-time or full-time equivalents. And by the way, according to the information we have, beginning in 2016, employers actually have to report that to the IRS, that yes, we had X number of employees and each one of them worked so many hours a week. And then on top of that, I know that I've got personally over $1,100 tied up in 2 training programs that I went through the American College early on to try to figure out, what our responsibilities are going to be in this. And then we have people in the office that have spent more money than that. So I can speak only for my company, but maybe Dr. Reinhardt can help here.
From the perspective of corporate cost, I can't even begin to give you an estimate. We have a very robust compliance process within our corporation, always have. It's funny, I was going to suggest they ask you about that because much of the advice regarding compliance we've gotten from our the vendor through which we purchase our insurance.
So would it be, and before I go to the other two, would it be a fair statement? Because I'm often criticized in my position because I'm not a fan of this bill. I believe there are things we can do. And before anybody says, well, you don't know anything about pre-existing conditions, I have a daughter with spina bifida. I get it. And there's a lot of other cost issues that we have out there. The money that you're having to spend and other businesses are having to spend, just for the record, could be spent on, if a business was doing better on job creation, better, working on better benefits. So would that be a fair statement, instead of having to spend it on compliance costs for something they're still not sure about?
Let's make a list.
What
Exactly.
he said.
Exactly.
One insurance company sat in my office the other day. Now, I can't verify this as being an accurate statement. I don't think the gentleman made this up, but he said his insurance company has spent $1 billion since 2010 in compliance. And off the record, I'll be glad to give you that name. You all can verify it.
Amazing. All right, back to my question now for both of you, whichever one want to answer. And if you don't, I completely understand. But also, one of the things I want to be able to do here is there is no doubt about where I stand on this law or any part of it. But there is a part of here there is an issue of how do we help people? How do we make sure? And not everybody is going to be helped, and especially the false dream that was proposed with this, because there is a balance here, and it never was intended to cover everybody. But in your specific case, just from your thoughts as a citizen, what do you think?
Okay, I've thought about this a lot, actually. As someone with a pre-existing condition, it would be great to be able to get insurance. However, I don't think it's fair for my husband and daughter to have to pay an exorbitant amount just to cover the risk for the insurers for me. We would prefer, as a family, my husband and I have discussed this at length, an a la carte system. Why he, as a man, having to have maternity insurance? That's ludicrous. Why can't we get catastrophic care insurance? Oh, wait, because we're too old. We're over 30. And that in the new system, you can't get it if you're under 30. I mean, if you're over 30. What we would prefer to have would be an a la carte system where we could choose what types of coverage we needed and take personal responsibility. If we choose the wrong ones, then okay, then we pay. And be able to have a catastrophic care plan. We're overall quite healthy, and to pay for our care as we need it. But then for those that can't, I love the community health centers. Expand those. That would help people like my son and daughter-in-law and their daughter. Expand those community health care centers for those that cannot afford, and offer the opportunity for catastrophic care for those of us that simply do not want to have to pay exorbitant premiums to cover every single little thing. And that would be what we would like to see happen.
Outstanding. Mr. Boyette, any thoughts on that?
Yes, sir. What I would like to see done the first time, let's do it right the first time.
Okay.
Get everything in order. How long, did these guys have to, prepare for this? October 1st, ObamaCare rolling out. 3 years, roughly.
Give or take.
Give or take. And that's a long time to get their stuff together. Keep their promises on stuff.
Well, I think what you bring out, I think is bottom line. It was, when you take the base bill, it was never able to work. It was never a thought out plan. It was never a vetted bill. It was never something. It was something we've got to pass because we have a set number of political deadlines and numbers. And politics is numbers. Bottom line, you have enough numbers, you can pass what you want. And that's what they needed. But they passed a bill that was not workable. That's why you have the 8-foot stack of regulations as we go forward. And I think that's why we're here today. And I appreciate, from the different perspectives, is here, yes, we got to find solutions. We're a country that needs to be a part of solutions, but a lot of that is just government getting out of the way and helping where it needs to help instead of trying to blanket plan and, in other words, hurt a lot of other people and compliance costs and everything else. And with that, Mr. Chairman, I yield back.
Thank you, gentlemen. Gentleman from North Carolina, Ms. Meadows.
Thank you, Mr. Chairman. Dr. Reinhardt, let me pick up a little bit on what you were sharing, because you were talking about the compliance costs and just that you've done a great job with that, but that it's just very costly. Are there any federal regulations that have come down the pike that have not ultimately cost you to comply with?
All right, here's a political answer. Without a little time to think about it, I can't come up with one off the top of my head.
All right, so let me ask you, for each dollar that we spend on complying to federal regulations, is that a dollar that is not spent on really providing health care to your patients?
I'm not sure that's a totally fair answer. If you're looking for compliance specifically with government regulation, some of that actually has resulted in
Better care.
well, I think absolutely some of it is better care. Some of it is increased and improved reimbursement to our practice in terms of programs.
But let me hit on that reimbursement, because I've visited a number of hospitals and a number of healthcare providers, and what they've said is they've gotten caught up in this having to make sure that they put down the correct coding, that it can get kicked out as Medicare or Medicaid fraud just because the coding is incorrect, when it's actually the procedure was justified, but it was instead of putting H2R, it was H2RA. Do you see that you have a big practice, do you see that as something that you have to spend just making sure your coding is correct to get your reimbursement?
I do, and I think that may actually be one of the advantages of the ICD-10 transformation we're going to go through. I will tell you that one of the great frustrations that we are struggling with right now around measuring quality of care is that how do you develop data banks that help us evaluate quality of care? Most of the data that's available is based around billing data and billing codes. As an example, if a patient comes to me who is a smoker, I can sort of submit a charge code for tobacco abuse. But if I counsel that patient, there's not much of a way for me to communicate with the insurance company that I did that counseling. That would be considered to be good care. So we actually are struggling to try to figure out how to communicate that we have done something that would be deemed to be quality to a system that largely just accumulates charges. And that's a great challenge for us.
So what you're
right
saying
now.
is there's an incentive to do another procedure or do something that would qualify for reimbursement instead of providing the healthcare counseling that would be considered a lot more advantageous to your patient?
I think you've hit on in large part on the reason for payment reform. Right now we're in a sort of a pay for procedure environment where if you do something you get reimbursed, rather than a pay for outcome, where if you do something well, you get reimbursed at a higher rate for accomplishing it better. And that's why we are trying to figure out how to report this quality information in a way that we can transfer or transform that incentive to actually do things into an incentive to do the right things.
All right, Mr. Sale, let me go to you, because you get to deal with a number of companies. Are you seeing any companies that you deal with that are not hiring people to try to stay below that 50 employee threshold, or if they are hiring people, that they're hiring them on a more part-time basis? Are you experiencing that at all? Are you seeing that with your clients?
We're hearing a conversation about it. I can't tell you that I have seen any of my clients that have actually done it. I do know that we have one client that I talked with the other day. Actually, it's not a client, it's a friend that works for this company. We're talking about their group size, and this person said, our company's at 40 lives and will never be more than 49 because we do not want to cross that 50 threshold. We have another person out in whose corporate headquarters out in the Midwest. Has over 100 employees, and they've just said, we're out of the insurance business, and they've been paying for the full cost of the employee, and they're giving the employees $400 a month. This particular person has come to our office, and to cover he and his family was going to be over $1,200 a month, if I recall their bottom line. So while I can't tell you that I have had actually an employer say, this is what we're doing, they're talking about it.
So Mr. Sale, you're saying that one particular instance that you gave at the end there, that you have people that are losing their health care coverage because he's getting out of the health care business altogether, and he's just going to purchase it for he and his family?
That is correct.
All right. Ms. Collins, let me come back and finish up with you. you've got a pre-existing condition.
Yes.
For many of us, we saw the covering of a pre-existing condition to be a good thing with this law. That we said, that really as a compassionate, fair country, we believe in taking care of our friends, our neighbors, and our community. And so I saw that. It came home to me recently, though, because I've got a sister with stage 4 cancer who's losing her coverage because of this Affordable Care Act and losing the ability to see her doctor because of that. Is that something that you're seeing with personally, or is it how are you going to grasp this with your pre-existing condition?
Well, right now, being uninsured, the pre-existing condition that I have is actually I have an artificial heart valve, and I take blood thinners every day. I'm always at risk for a stroke or for some kind of incident like that. We're just aware that right this minute, if I had something major happen, then it would very potentially be catastrophic for our family. So as someone with a pre-existing condition, I would love to have a catastrophic care plan that would cover me.
So you're saying under this, the ACA, that you, because of your age, and I know that you may be 29, but because of your age, you don't qualify for a catastrophic plan.
Correct. I'm 47, and otherwise, and I'm great health, and I don't qualify for that now. And before the ACA was passed, I didn't qualify for any plan. We were rejected by multiple companies because of my issues. So I was very happy for it to be that aspect. I thought, this is great, but it's unfortunately not been the case.
So
for us.
basically, what you're telling me is that this is the American people being forced to buy a particular product at a particular price, to not be able to make those choices on your own.
Right.
Which means that ultimately you're having to not make other purchases that perhaps you and your family would make, because you're having to focus on a narrow set of what the ACA is forcing you to look at.
Absolutely. Given the financial burden that we will be bearing should we comply with the ACA and all 3 of our family members have insurance coverage through it, our discretionary spending would plummet dramatically. And like I mentioned in my statement, we have people that we hire around the house to do different things. And that in and of itself would probably not make that big of an account in the economy. The fact that we go out to eat, or that we go to the local shops, or that we buy from our local car dealerships, or whatever we do, us alone aren't going to make that big of a difference. But all the people in our situation, they're going to have no choice but to do the same thing. And that's frustrating.
Well, thank you, Ms. Collins. Mr. Chairman, I yield back.
Thank you, Mr. Meadows. Dr. Gingrey.
Mr. Chairman, thank you. A couple of my colleagues asked the question, could we have done any better? I think maybe a more appropriate question would have been, could we have done any worse? Because I absolutely don't think we could have done any worse. I do think we could have done better. Let me just offer a suggestion, and then ask the witnesses to see how they feel about this. I haven't worked out all the fine details, and maybe it's a little bit half-baked at this point, but you understand, the witnesses, and I'm sure everybody in the audience, something called COBRA, Consolidated Omnibus Budget Reconciliation Act of 20 years ago or whatever. But what COBRA allows is that you're working for a company, and you get laid off, the company downsizes, or you quit for some reason, you decide to take another job. You can continue to be in that group plan that company has offered, and maybe you've been there 15, 20 years, and everybody pays the same premium. And you've been in great health. You started it right out of college. You are 10 feet tall and bulletproof. You don't smoke, you don't drink, you don't skydive, you don't do any dangerous things, and you have had very few claims. So the insurance company that has that policy for that company and those employees has really done pretty well on you. I hope you, the hypothetical you, is getting an annual physical or maybe a physical every 2 years. But bottom line is the health insurance company, as far as that group is concerned, has really made a nice profit off you over 10 or 15 years. But during that time, you could have developed high blood pressure. You could have developed type 2 diabetes. You could have had a malignant melanoma. You could have had a heart attack. You may well have had a stent put in. And then all of a sudden, though, you're fine, you're recovering, you're working, you're still working, but you find the ideal job that you want to transition to, or that you get laid off and you lose your job. So federal law allows you to continue in that plan for 18 months, right? 18 months. You have to pay the entire premium, don't you? Not the employer part. If it's 60%, if it's 50%, whatever they pay, you have to pay it all plus a 2% administrative fee. And you have that for 18 months. And let's say that at the end of 18 months, you're 52 years old. What in God's name are you going to do until you turn 65? You're not disabled. You just now have a pre-existing condition. Well, why not, and this would be my question to the panel, why not say that a person in that situation should have the option to own that policy and continue to keep it until they turn 65, if they want to, and pay that premium, and not put them in that god-awful position of not being able to get coverage, be denied, or if they could get coverage, some new insurance company say, well, yeah, but 5 times standard rate or 8 times standard rate. Now, that's called health insurance reform. That's really what we needed, I thought, from the very get-go. That's why I say, well, we couldn't have done worse. We darn sure could have done better. But let me just ask, and Mr. Sale should be the expert on this, and don't be afraid to shoot holes in this because, as I say, I haven't fully thought it out. But believe me, we do have other ideas. Mr. Sale.
It's a good idea, Congressman. And the idea of being able to keep insurance is certainly important, because the one thing that the law could have done prior to the PPACA law is to have a pool for the uninsurable individuals, those who no fault of their own end up being placed in that category. It doesn't need to be, it just could be molded in with all the other cost of coverage that we have. That idea of keeping your COBRA coverage or going on, extending it, is certainly not a bad idea.
Well, I appreciate your response, and then we'll move over to Dr. Reinhardt. But I mean, you even could say pay a little bit more for your premium for that option, for that ability, if you're willing to do that, if that's necessary actuarially to make it work. Dr. Reinhardt.
I think the word actuarial is a good word, because the implication there, if you were to allow a person to do that, is to calculate what the expected cost of care for someone with that diagnosis, say type 2 diabetes, what is the expected cost of care for that individual for medications, comorbidities, including their increased risk of heart attack, high cholesterol, and things of that nature. What are the expected costs for that individual, and should not that individual be expected to pay for those things? And so we go to the actuarial tables, and you can all boil this down to math, statistics, and whatnot. What is going to be the cost of that person during the course of their lifetime? Better yet, what's going to be the cost of the care for that person in this particular calendar year, age 52, et cetera? And essentially that number is amortized over the course of a year. These are companies which, according to the law, are allowed to make 15% profit or whatever it is. Their loss ratio can be 85%. So I think that, I think that sounds like a good idea, but I also believe that the patient should be required to pay for the expected cost of their care during that
Dr.
period of time.
Reinhardt, thank you very much for bringing that up, because I may not have made myself completely clear on that. That option to continue that COBRA for until you reach Medicare age, because you now have these pre-existing conditions. That option, of course, would be only from that insurance company that had that group policy where you were a member paying a premium for a set number of years. I would say that if you work there 1 year, no. But if you work there 10 years or 15 years, some break point where you say, surely this particular health insurance company, whether it's a Blue, Cigna, Aetna, United, you name it, has made enough money off of you already, and surely they would have the compassion and the good marketing sense to be willing to cover you until you turned age 65.
I'm gonna let Ms. Collins speak on that. I'm not too.
Okay, as far as the COBRA, I could see there could be some benefit in that. It would concern me the cost that would end up going on into. I would love to see a health savings account. I think the HSAs were great, and see those be rewarded, and see as many people as can take responsibility for their own health care costs without bankrupting themselves. But also cover the people in the middle, like the woman that Representative Meadows referenced with pancreatic cancer. There needs to be something to cover that, where you can't just be cut off when you're in the middle of treatment. That's basically going to be a death sentence. So I like the idea of the COBRA. I think there's some other things that I would love to see happen. Like I said, some more individualized choices and more individual responsibility. Yeah. And that sort of thing.
And they're all in here as part of the American Health Care Reform Act, Republican proposal coming out of the Republican Conservative Study Committee of the House of Representatives. So, Mr. Chairman, my time has expired. I thank all of you. I thank all of the witnesses. Y'all have been fabulous. Thank you, Mr. Chairman. I yield back.
Thank you, Dr. Kingery. Ms. Collins, I'll say to you, there's a bill out there called H.R. 25, the fair tax. That's a subject of a different hearing for a different day, different hearing for a different day. But changes all of those tax incentives so that you and I can buy that policy when we turn 18, take responsibility for those decisions. Everyone on this panel up here is a co-sponsor of that fair tax, and it's amazing how many of these decisions come back to the federal government and how we've pushed behavior in this direction instead of allowing it to take that natural course. For the final word, I'd like to yield to Doug Collins.
I appreciate that, Mr. Chair. One, something was said early on about the attendance. And I have the great privilege of representing Georgia's 9th Congressional District, and I tell them all the time, is it not only one of the most conservative districts in the country, I believe it's in my humble opinion, the best district to be able to represent. And it's shown in this room today. Dr. Gingrich, this is normal in Georgia 9. This is normal in Georgia 9. We've been around a great deal because they're passionate, because they believe in individual freedoms. They believe in a government of a constitutional role. And I think these are the things we've talked about today. And a problem with a bill that, frankly, may at some point have had good intentions, but bad ideology. It had bad ideology to say, we're going to fix it for everybody, but maybe not you, and maybe not you, but yet sell it as if it would. Cost to the person may go down for some. It may go up for others. But for everybody, as taxpayers, you will pay for this plan, like it or not. And so when we look at this, I just want to thank the staff, my staff that is here today that worked very hard on getting this done, our district staff, our Washington staff, and I just want to thank them, and they're in the room today. They're very special to me, and I appreciate it, and they will be here. If you have those statements that you would like to submit to the record, you can get those to us and be a part. The OGR staff, again, we talked about, are great and to work with and to get this put up, and Chairman Issa and the rest of the staff. To my colleagues that I've shared the dais with today, it is special to have you here with us today, and Congressman Woodall, Meadows, and Gingrey, and Ms. Kingston had to leave. It's just here that we're trying to do what we promised, and that was to listen and to be a part and find solutions as we go forward. The witnesses who've taken their time. But I do want to take one moment here to remember a witness who's not here. Josh Kinsey was intended to be here today. I got to know Josh when I'd go to White County, and I got to represent White County while I was in the State House. Josh ran a little pharmacy on the square. Had a little soda shop next to it. His pharmacy was there. And Josh is just one of those guys in the chamber. He's just one of those vivacious kind of guys that you just like to be around. He's closed his practice because compliance cost, because the uncertainty of this law and the uncertainty of health care. He made a choice that he had to make for him and his family, which I find no fault in. You have to do that. But here was another example of an independent pharmacy and others in healthcare having to make choices that limit choices. Do not expand them. They limit choices. He went to work for a bigger firm, and that's great. That's what needs to happen in his life. But I'm saddened today that he couldn't be here because he just started his new job and couldn't be here to tell you about the folks that he took care of and how this has affected him. I make this statement all the time. What we do is a lot about paper, but in the end, it's all about people. And that's something we can never forget. So we look at that, the people in this audience, you make it up, these witnesses, my colleagues. It's just good to be here today, but also to still be in a country where we can still debate these and find solutions. And with that, I yield.
Yeah, thank the gentleman. As all of you all know, America's not run by 51% of Americans. It's run by the 51% who care enough about America to show up. I thank each and every one of you who took time out of your day to be here, both the folks who came to give us their testimony on the panel and those who came to be with us in the hearing room today. And with that, the committee stands adjourned.